Dr. Chris Bleakley has sat through many of these, as he has been quite the committee member for a long time of ACPSEM in the past. He's now a senior lecturer at Ulster University, but is an internationally recognised expert and researcher in the field of musculoskeletal physio. He earned a Bachelor of Science in Physical Therapy from Ulster University in 2000, completed a PhD in 2004, and after working as a clinician at the Sports Institute of Northern Ireland, and in private practice, he completed a Cochrane Fellowship, undertaking a research fellow position at Ulster University in 2008, and moved to the United States in 2017 to High Point University. He's a founding chair of the Masters in Sports and Exercise program at Ulster University and continues to undertake clinical-based research, producing over 100 peer-reviewed scholarly outputs. I can tell I didn't write that, but his main areas of interest include acute soft tissue injury management, chronic ankle instability, and sports epidemiology. He's an invited committee member of the International Ankle Consortium since 2012 and an external examiner on PhD theses and a peer reviewer for over 20 scientific journals. I heard him speak in Barcelona just over a year ago at the conference on this topic, fresh from the Foot and Ankle Symposium, and I thought he was absolute dynamite. He was absolute gold in the session among so many experts. So I've been dead keen to get him onto a global audience since. So I'm thrilled he's going to be sharing with us tonight. So I hand over now to Chris Bleakley.
Look, thanks very much for the opportunity to chat. I kind of took the slant on looking at the first half of the lecture to consider why ankle instability is so common. We see it all the time, and try and break it down into really three main reasons. And then look at a positive spin at the end. What can we do about it? So just to warn in advance, I'm going to whine a little bit at the start and then come up with some solutions at the end. We all know how common ankle sprains are, and a little bit of ropey stats from me suggests that around 1 in every 200 people sustain either a sprain, a re-injury, or a giving way episode each year. That is based on data that we have on emergency department attendance, but we actually also know that only about 33% of people who sprain their ankle will actually attend some type of emergency department. So that's probably an underestimation in many ways. So they happen a lot. We also know that after they happen, we get large chunks of people, large cohorts who don't fully recover. And this patient type who present with long-standing pain, loss of confidence on their ankle giving way, or a recurrent injury, they've kind of been labeled under this umbrella term chronic ankle instability. And this is pretty important because we also think that the development of chronic ankle instability is an important mediator for the development of post-traumatic osteoarthritis. And even though post-traumatic OA is less prevalent than knee and hip OA, most of the post-traumatic OA is driven by trauma rather than other factors that are associated with knee OA and hip OA, for example. The mechanisms are, I mean, we can only really postulate these because there haven't been very many prospective long-term studies, but it could be just the macro trauma of the initial injury and the potential for osteochondral damage in a sprain, then just developing over time. We also know that lots of syndesmotic injuries are missed, and there's some pretty nice data to show that if you have an instability in the syndesmosis, so a high ankle sprain, that hasn't fully recovered, has been missed, or has been left with a level of residual instability. So a 2 mil increase in the ankle syndesmosis, a 2 mil gapping increases the loading force at the ankle by about 40%. The other reason why chronic instability and giving way may cause OA is simply just down to the multiple episodes of giving way that people have. So every time the ankle gives way, they, impact and compress their talocrural joint a little bit more. And we also know that people with chronic ankle instability have a more predictable sensory motor system. They don't have that nice natural variability that a healthy sensory motor system will have. And that means that they load their joints in the same way over and over and over again. So you get some areas that get stress shielded from load, and then other areas where the load is massively concentrated. So we know it's a problem, we know it's common, and it's a mediator for longer term problems. But why do we see so many of these? Well, the first reason, there's not actually that much that we can do about, but it's really interesting to talk about it, is that we're predisposed. If we look at how the foot has changed over time through evolution, the human foot has really rearranged itself around the subtalar joint axes. And it has developed to form this twisted plate appearance. So we developed a medial arch and a lateral arch and a transverse arch. The talus became more stacked on top of the calcaneus. Our cuboids got a bit longer, and we can see evidence of this even through the kind of low torsion that we see in our fourth and fifth metatarsals. So we've kind of gone from having a pretty flat foot to this twisted plate where the talus is stacked up. So that inherently decreases the base of support and makes it a little bit less stable. We also have muscles that have got a frontal plane dominance, and a lot of injuries will happen in the transverse plane, as is shown in the picture here. A lot of injuries occur due to a sudden change in frictional quality. Again, looking at the picture in the middle of the Liverpool player who has just stepped back onto the strip of AstroTurf that runs down the side of the field. So he's gone from a lower frictional quality to a higher frictional quality, and that has developed or induced this supinatory moment. And typically when these supinatory moments result, they occur on the outside border of the foot. And if we think about the position of the subtalar joint, I'm just going to get my arrow options here. So if we look at the location of the subtalar joint, these external supinatory forces are always going to win against the internal pronatory forces because they're further from the axes of rotation and they have got higher levels of moment. And the other thing we need to remember is that these injuries happen immensely quickly, and our sensory motor systems often can't respond. So if we have got an error in the feed forward component of our sensory motor system and we're off at initial contact, as is happening with this high jumper, by the time we get to 0.04 seconds, it's already too late, the damage is done, and it's very difficult for us to generate internal moments quick enough to overcome those external supinatory forces. We also have an odd-shaped talus that we know about. So remember when we're looking down at the talus, so this is taking a kind of top view, looking down at the proximal articular surface. It's an odd shape, and it's a little bit wider at the front than it is at the back. And that's why whenever we're in a dorsiflex position, it's more closely packed and more stable. And then when we move into plantar flexion, it's the thinner posterior aspect that occupies the bimalleolar pincers. And again, that's our loose pack position. And it doesn't mean that every injury and every sprain happens in plantar flexion. Injuries can happen in dorsiflexion, of course, but that movement makes it a little bit more unstable. if we look at the structure of the ankle, we know that it is not just an ankle joint we're talking about. We're talking about three joints within this entire complex: our syndesmosis, the talocrural joint itself, but also the subtalar joint. And that is, as we'll see later, it tends to be the forgotten joint. But it's really interesting. And if we look at, let's say, things like the ligament morphology and makeup, it is really, really thick on the medial side in comparison to the lateral side, which is relatively sparse. So these ligaments are really big. They span, on the medial side, 75% of the ligaments cross both the ankle joint and the subtalar joint. So there's the tibionavicular, testing my anatomy here, that's the tibio spring. So that actually inserts into the small spring ligament that is shown in the right as number 5. And this wraps right across to kind of hug the joint. And then there's just the regular tibiocalcaneal, and then there are deeper ligaments on the front at the back. So this is the superficial layer, and there's also a deeper layer. And the reason why they need to be so strong in the medial side is because, remember, our foot is stacked up into that twisted plate position, which means it is primed for pronation. So think of the ankle complex as a triplanar joint. There's lots and lots of rotation going on, and that should impact how we assess it and also how we load it moving forward. And the subtalar joint has kind of been described as a mini knee. And again, if you just pause this at the end, you see this, you can see the meshwork of tissue that sits right in the middle. Sorry, I can't pause it, sorry. That sits right in the middle. That's the interosseous ligament. So we can see it in cross-section on the bottom right. And that's been referred to as the cruciate of the ankle. And it does a similar role to the cruciate in the knee in that it controls rotation. So again, looking at the movement on the right, there's a significant amount of transverse and frontal plane movement at our ankle complex. And that's what our subtalar joint is there for. And remember, a subtalar joint is split into two. So the posterior component of the subtalar joint is primarily translational, and the front part is much more akin to a ball and socket. And again, that's why we've got such a thick medial side and such a sparse lateral side. So we're built to pronate and supinate. And again, on the image on the left, we can see that position where the talus is stacked up onto the calcaneus in supination. And in that position, our foot, we're asking it to act as a rigid lever, essentially. And then the opposite happens in pronation when the talus, which is essentially an extension of our shank, drops down and moves in, and they span out and they become less stacked, which makes for a more mobile shock absorbing unit. So we're really asking our ankle complex to take on these really paradoxical roles of energy absorption versus acting as a rigid lever. And that can be challenging because we're also asking it to move quickly and often in surfaces with variable traction. But ankle sprains are a natural consequence of bipedalism and the changes that have occurred within our arch. We've got proximal muscle attachments, and they're always going to lose against ground reaction force, and a relatively slow sensory motor system relative to the speed of soft tissue injuries. And we also know that once we start on the pattern of injury, then previous injury becomes a primary factor. So whenever we're thinking about an etiological model as to why ankle instability is so important, we have to think that there are modifiable factors and ones that we can't modify. So a lot of the predisposed box we can't modify. There are a number of factors that we have identified through prospective work that seem to make people more susceptible, that we may be able to change. So people with higher BMI are more likely to sprain their ankle. People with reduced inversion and plantar flexion strength primarily, and reduced joint positional sense and reduced reaction time. But again, I have to stress that the evidence in that area isn't particularly good. And then obviously we've got an inciting event, which we'll come on to a little bit later on. So the first one, there's not a lot that we can do about it. What's the second reason as to why ankle stability is so prevalent and we see it all the time? Well, misdiagnosis. When you scratch the surface and look at how well we can assess acute ligament injuries, we think we're really good at it, but actually there's not a lot of depth to it. And I want to provide some data to back that statement up. We are good at some things. We're really good at examining the ATFL. So the ATFL shown here in green, often it is a kind of bipartite ligament. Sometimes people have 3 bands of ATFL. Some people have 1, but regardless, we're good at assessing it when it is injured. It's best assessed slightly after the event, so maybe 72 hours once the pain and swelling have settled a little bit. But that's a nice test to use. The best thing to do actually is to use a test cluster if you want to identify an ATFL tear. So use palpation at the start because that's a sensitive test, and then use the ATFL, which the anterior draw test, which is shown at the bottom, which is more specific. So palpation is sensitive but not specific. The anterior draw is a little bit more specific, and you're better clustering them in that particular order. And if you do that, you will rule these in and rule them out really accurately. What we're not very good at is assessing the CFL. And the reason for that is that CFL, first of all, isn't very palpable. There's only a very small component of CFL that we can put our fingers on. It's primarily covered by the peroneal tendons as they run around the lateral malleolus. And the Taylor tilt test, which, by the way, I wouldn't, it's a poor choice of diagram on my part. I wouldn't test it like that. But even if you test it really nicely and cup your hand right around the calcaneus and talus, it is a specific test, but it's not that sensitive. So don't get too excited if you get a negative finding. Get excited if you have a positive finding. It's probably definitely a CFL tear, but just be wary of false negatives with that type of test. The other thing to remember is that CFL is rarely injured in isolation, and it's often injured in combination with an ATFL. These are definitely ones to look out for. And again, they're commonly missed because of the problems with the test sensitivity. And remember, on the lateral side, the CFL is the only lateral ligament that crosses both the talocrural joint and the subtalar joint. And because the talus has no muscle attachments, it relies on those ligaments a lot to stop it from moving about uncontrollably. High ankle sprains have traditionally been missed and have traditionally been underestimated. We used to think that in a regular ankle sprain, about only 2 or 3% had some type of syndesmotic involvement. In 2014, there was the largest MRI-based study prospectively undertaken, and they reckoned about 20% of clinically diagnosed lateral sprains actually had either isolated syndesmotic injury or concomitant syndesmotic involvement. And in a recent meta-analysis that I've been involved in, we find the median prevalence, to be around 20%. So we have to make sure that we don't miss these, because they add or throw a massive spanner in the works, because their recovery period is typically far more difficult to predict than with a regular sprain. And again, we can see here, obviously, the variations in return to play depending on the amount of instability that's there. But even with a grade 2A, using conservative treatment, you're looking at a median time to return to play or return to sport of about 45 days. There are bucket loads of different tests that are bandied about in the literature that are proposed to be good at diagnosing a high sprain. I think the thing to remember is people assume that they have all got equal accuracy, but they really don't. And not one of them has got good sensitivity and good specificity. Additionally, they are primarily tests of pain provocation, not instability. So they're different than an anterior draw test. What the majority of these tests will do is they will recreate pain, but it's very difficult to determine the amount of gapping that you're getting at the syndesmosis using these tests. And that's been shown through a number of cadaveric models. So what do you do? Well, again, we've looked at this evidence recently, and we have a meta-analysis that's, again, currently under review. But you've got to cluster these, and again, you're better doing your sensitive tests at the start of the examination. And palpation is a really sensitive test. It's got terrible specificity, but it's good for ruling out early on, and then combine the sensitive palpation with a more specific squeeze and external rotation. So you should have higher suspicion of syndesmotic involvement if somebody has got pain at rest, if they've got more proximal swelling, maybe if they're involved in contact sports or they're reporting a external rotation mechanism, but again, they're not typically that reliable, especially if you aren't looking at video replays. So palpation followed by squeeze, and have a high index of suspicion if there's also additional medial pain, posterior pain, proximal pain along the interosseous membrane, and a positive external rotation test. And generally speaking, if any of those are present, they do have a worse prognosis, and it's generally more indicative of instability greater than a 2A that will require surgical intervention. And James Calder's published some nice algorithms on this. But the crux is that these are commonly missed. So stick to that cluster and that combination, keep a higher index of suspicion, and they're less likely to slip through the net. This was a consensus document that was really encouraging clinicians to also incorporate more of an impairment-based approach to their clinical examination. And I think it's pretty good, and it's a really good start. But there are also some problems, because we don't have really any tests that are good at examining the stability in the subtalar joint. And I think the other thing is, and this was the focus of a recent editorial that I was involved in, if we think about the number of ligaments that support the ankle and midfoot complex, all of them are at risk of injury and can be injured during a lateral sprain. But how many of those can we actually pick up through clinical tests alone? And this idea of micro instability within the ankle that is occult to our clinical examination, I think is being picked up and being talked about a little bit more by some of the foot and ankle surgeons. And that's definitely something to keep an eye on. Third reason, why is it so common? Terrible evidence base. If we think about risk factors for people developing chronic ankle instability, you would think that there are reams and reams and reams of prospective studies that have looked at risk factor development and taken big pools of people with ankle sprains and followed them up. The reality is that there's only one prospective, and there's only really one other large study in this field. So it's a pretty poor evidence base to be making our decision making on. There are similar problems within the experimental evidence base. And again, we could zoom out and criticize really all of sports medicine. But one of the things that Jamie Smolligan and I wanted to do in this editorial was to challenge researchers to increase the height of the bar, and also to challenge clinicians as well, to increase the height of the bar for what constitutes evidence. And unfortunately, in the scientific world at the minute, p-values and having a p-value less than 0.05 seems to be the bar that we set before we determine whether something is useful or not. And we need to look beyond that at the quality of the research registration, but most importantly, whether or not the findings that are statistically significant are also clinically important. In other words, are they big enough for you to care about as a clinician, but also, most importantly, big enough for the patients to notice? And then finally, science is based on replication. It needs to be replicated. And if one of the things that we did recently was took kind of a deep dive into the ankle literature and experimental studies that involve people with either lateral ankle sprains or chronic ankle instability. And we found 74 large randomized studies, 77% of which were reporting evidence of effect, evidence of treatment effectiveness, primarily based on statistical significance. And again, if you keep raising the bar, how many were registered? Only 19%. How many also had a low false positive risk? In other words, how many were believable? 15%. And how many of those 77% were also associated with clinical effects that were deemed to be important by patients? Only 4%. So we're not doing too well as researchers. And that's not anything for you to worry about as clinicians, but it's certainly something that the research world needs to take on. So what can we do about it? I've highlighted a lot of problems. What can we do about it? Well, I've talked about ways to try and enhance diagnostics. So with the lateral ligament, remember to combine the cluster. Sensitive tests before specific. Anterior draw tests become a little bit more accurate if you add some internal rotation at the end of them, because remember how the ATFL, it's not orthogonal, it makes an angle with all of the planes of the body, and it gets recruited a lot during foot internal rotation. So include that. CFL is only useful for ruling in, it's not useful for ruling out. And be wary of combined injuries, because they provide, or they are associated with, considerably more problems with joint biomechanics, and they will massively affect the subtalar joint. I talked about high sprains, mechanism, pain at rest, and again, combining the test cluster of palpation, squeeze, and external rotation, and be particularly wary with proximal pain extending up the interosseous membrane, any posterior pain, and of course medial pain. These aren't good prognostic signs. Subtalar joint, I can't help you a lot with, but just remember that it exists. It rarely exists in isolation. So it normally, subtalar joint instability normally exists in tandem with talocrural joint instability. And if you look at some of the recent imaging studies, the ligaments that support the subtalar joint, the CFL, the cervical ligament or the ligament of the neck of the talus, and the interosseous ligament, which sits right in the middle, that cruciate ligament of the ankle complex, they can all get damaged with sprains. So I think we're missing a lot of these. There may be a link between people who develop sinus tarsi pain after a sprain and subtalar joint instability, and also those who show evidence of whitening on MRI in any of these ligaments. There have been a couple of stress tests, but again, the diagnostic accuracy is pretty poor, and they were mostly a little bit like subtalar joint mobs or medial glides of the calcaneus, and they don't tend to work particularly well. What can we do in terms of our intervention and a rehab? Well, target key impairments. We know to some degree from the limited prospective research and the large bank of cross-sectional research that people who go on to develop chronic instability and have a problem ankle typically will have poor postural control and reduced sagittal plane excursion from pretty early on after their initial sprain. So be wary of these two things. There are other things that are also associated, but higher arch height and a history of more giving way episodes, we can't really modify. The inability to perform a drop jump landing at 2 weeks after an injury, I think, has been associated with somebody who develops instability irrespective of their clinical grading. So we think that that may have something to do with maybe kinesiophobia, people who are reluctant to load in the early stages. But again, we can't imply causation. We don't have enough data for that. So remember, get the sagittal plane first, master that before thinking about anything else. Decreased dorsiflexion is also roughly associated with people with chronic ankle instability. Recently, a really nice research study that I was involved in at the end with some of the guys in Aspetar, they kind of flipped it and they looked at weight-bearing dorsiflexion. And one of the rationales for that was that the arthrokinematics are kind of reversed when you look at open chain versus closed chain movements. And what they did was they compared people with chronic instability or people who were at the kind of end stage of rehabilitation with a group of healthy controls. And whilst dorsiflexion was decreased, which is what we really would expect, the biggest difference between the two groups was that the injured group or the recovering group also had a really big deficit in plantar flexion and inversion. So inversion, maybe not as surprising. Plantar flexion, I think, is something that we forget about a little bit and tend to focus in everything's on dorsiflexion, and that's important, but don't forget about plantar flexion when we talk about mastering the sagittal plane as early as possible. Postural control, I mentioned, is decreased. The other thing we know is that it's not just about the ankle, and there are deficits all the way up through the kinetic chain as people develop chronic ankle instability. So if they do something like a star excursion balance, not only do they have a decrease in their reach, but they'll have a decreased hip and knee flexion. They tend to develop this hip strategy, so they take their ankle out of it. And if you look at their center of pressure on a force plate, it actually becomes less variable in comparison to a healthy control. Again, that comes back to that kind of Goldilocks effect with when it comes to motor control and variation. You don't want too much, but you also don't want too little, because too little is indicative of a really rigid sensory motor system. So they tend to fixate on one spot, and that's not good and that's not healthy. So that's something that you need to think about trying to break down and just be wary of when you're giving people single leg balance or proprioceptive exercises. And also remember that you need to move beyond the sagittal plane when it comes to postural control challenges. And we can give people lots of these exercises and stand in one leg and on balance boards. But if you actually think about what you're trying to do, which is ultimately recruit the damaged ligaments, then often they are not being challenged at really deep angles. In fact, often they don't really get that far past the neutral position. We know that in general, around the ankle and at other joints, our joint positional sense gets worse and worse and worse the deeper the angle becomes. So as we move into more and more and more plantar flexion and inversion, we become less aware of where our joint is in space. And what you can see here on the graph on the right, if you follow the straight line, the thick line, that's somebody without any intervention. So their joint positional sense error got worse and worse and worse the deeper that the angle got. And the dotted line is indicative of a group who were given joint positional sense training. So if you train it up, people will get better, but you need to move beyond single leg balancing in a neutral position in a plantigrade position at approximately 90 degrees. So remember about the anatomy. If it's a CFL or an ATFL, they get recruited at different points. So if it's a CFL and we really want to recruit the ligament, then we need to actually move the foot into more dorsiflexion. So think about maybe trying to run some balance exercises in either extreme. ATFL, as you can see there, gets recruited and becomes a true lateral stabilizer in extremes of plantar flexion. So make sure that you bear that in mind when you're prescribing, and even small changes to foot position when you're doing postural control exercises can make a big difference in terms of ligament recruitment. And also remember that we're not dealing with ligaments that sit exactly on the three body planes. The ligaments that hug around the ankle, they make angles with all of the body planes. So it's absolutely imperative that in addition to training deep angles, that we bring some type of rotational load and rotational challenge. And again, we're working the left foot here with a spinning force on the transverse plane. Again, that's much more likely to recruit the lateral ligaments in a nice anatomical way. Consider the biomechanics of injuries. This is something that can help us get better at managing these. We know from loads of lab-based studies that injuries typically happen with an error in the open chain, whereby just before initial contact, the ankle is in excessive inversion or internal rotation. And we know that when initial contact occurs, the injuries happen so quickly that we don't have the restraint mechanism to get out of that. Essentially, it's a bit like you crash the car and the airbag goes off 5 minutes later. We can't respond quickly enough. So we need to make sure that we are decreasing the risk of making a joint positional sense error in the open chain. And that's kind of the opposite of what we do clinically. And certainly if you look at research interventions, they spend a lot of time in the closed chain doing lots of postural control exercises, which is great, but that also needs to be balanced up with joint positional sense work in the open chain, because that's typically where the errors will occur. And again, there's loads of ways to do this. Early on, it's really important to flood the system with afferent stimulation, and I don't care how you do it, but you can use hands-on work, you can use taping, you can use manual therapy. And Patrick McKenna and Eric Wickstrom have written a really nice study about this called sensory targeted ankle rehab. And that's really what the crux of it is, trying to stimulate the system with afferent information. I think largely we do that pretty well. Bring back PNF has been a call of mine for a while. It is really, really valuable in the early stages after ankle injury. One of the things that we know with ligaments when they're healing is that we don't need to evoke massive forces in order to induce a mechanotransductive effect. So even small loads, small magnitude loads will help with healing. It's also a really nice way to start to challenge all three aspects of proprioception. Remember, proprioception doesn't just involve being able to balance on one leg. Strictly speaking, it involves a kind of tripartite of joint positional sense, the sense of force magnitude, and also the sense of force direction. And you can challenge that really early on with all of the PNF principles. The other nice thing about it is that it's open chain and it replicates and challenges some of those things that we get wrong. And like any type of sensory motor challenge, we need feedback. Often researchers in their interventions will give out pretty mindless mobility or even balance exercises where there's no focus, there's no challenge, and there's no feedback. And part of retraining the sensory motor system is to allow the patients to have a go, to make mistakes, and to reestablish all of those little neural networks. Again, this is just a bog standard laser pointer taped to the foot, and all we were getting this person to do was to track little different ways through the maze. And if you look at their ankle while they're doing it, they were pretty shaky and pretty poor. And again, the more they went into deeper angles of plantar flexion and inversion, the more shaky that they got. When it comes to strengthening, we need to move beyond the inner range eversion loading with a TheraBand. Think about different ways to isolate the muscles, and this is difficult because when we think about our tib post and our perineal muscle group, they wind and they cross more than really pretty much any. I can't think of any other musculotendinous unit that changes direction more than the peroneus longus. So it crosses multiple joints, it crosses multiple planes. So we need to add in a wide variety of exercises in order to challenge it. Think about loading in the transverse plane and trying more eccentrics. So let's look at some of the reasons why this is important. One of the things that we know with people who have chronic ankle instability is they do this really counterintuitive thing where they tend to load more on the lateral side of their foot. And that's counterintuitive because you would think that that puts them at greater risk of catching the outside border and initiating a sprain, and that's absolutely true. And we need to try and break that cycle and normalize their gait pattern. We don't know why they do it, but there are some theories. One is that they have to go into that level of inversion in order to get some type of afferent feedback because the ligament is stretched or is lax and doesn't fire off until further into the range. The other thing may be that we lose efficiency in pronation and in supination. And to compensate for that, we lock our ankles into more of a supinated position where the talus is stacked up in the calcaneus and we just load our foot as a rigid lever. And again, that makes a lot of sense because the talus is really an extension of the shank. And as we move into pronation, as the tibia internally rotates, then the talus follows it. If we cut two of the major ties between the talus and the lateral malleolus, and also remember that the talus doesn't have any direct muscle attachments, then there's an increased risk that it kind of starts to float about on its own. and we lose that link and that coupling that the subtalar joint gives us between the foot and the shank. So it's really important to target pronation and target supination. The TIB post and the FHL can help us with that. We also know that in an acute sense, because of joint distension and pain, that many of these muscles get inhibited. So the TIB post and the FHL work really well to kind of arch right under the talus and the medial side, and they support pronation and help spring the foot back into supination. And the subtalar joint itself has been likened to a metered hinge. So we don't want to lose that coupling that we get between the foot and the shank. And what that allows us to do really efficiently is to move force from one plane, from the frontal plane to the transverse plane. And if we lose that and our foot starts to work as this compensatory rigid lever, then we start to load up areas of the foot that don't like it and also increase our risk of further injury. So doing some shank on foot exercises and strengthening is really good. Don't be afraid to get people into supination early on, as long as it's not too sore, and get them working the same thing in plantar flexion. So shank on foot strengthening is almost and arguably more important than open chain strengthening. So underused. Other areas that are effective are pronation control. Remember that peroneus longest part of its role is it wraps around the lateral malleolus, but then it changes course to wrap underneath the foot to insert in the first ray. And again, if we lose that, then we lose that ability to keep that first ray planted when we go to push off. And that's really the nice rigid part of our foot that gives power and pop during push off. Remember that part of the peroneal's role is also to function as a positional tendon rather than a part tendon. So again, it's important to train it like that. And on the right, that's just a little modification to try and train it through its role in preventing excess movement in the transverse plane. It's really difficult to isolate some of these muscles using eccentrics, but eccentrics are brilliant because they obviously load the musculotendinous unit more, they maximize the afferent input, but the challenge comes, as I mentioned before, because these units cross so many joints and they change plane. So the setup that I would typically use is inside line because it takes the hip out of it, make sure the hip is in slight adduction, and give them some feedback. It's really difficult for patients to know what you want them to do. And again, just like you would with a Norwegian hamstring curl, the idea is that you've got to maximize that wedge that the muscle is working through. So they've got to work the whole way through, right to the end, to start to train some outer range rather than the bog standard inner range TheraBand work. Mozzarella mechanics, again, this is really to make you aware of the importance of getting the peroneal muscle group and tibialis posterior switched back on again. We know that they're massively inhibited after the acute phases. And we also know that with pizzas, the easiest way to stop them from flopping forward, as is shown on the right, is to bend the base of it. And that stiffens the longitudinal component of the pizza and stops it from flopping forward. And there's a postulation that our medial and transverse arch work in a similar fashion. The transverse arch is there to help stiffen the medial arch. If we lose our transverse arch, then we will also lose some stiffness and recoil within our medial arch. And if you look at the orientation of tib post and peroneus longus, they have got quite an expansive distal attachment, and they also cross over, and they cross right down past the midfoot. So whenever they tighten, whenever they're activated, they have this kind of crosswire or drawstring effect to help the transverse arch from collapsing. So again, this is something that we overlook. I think certainly within the research literature, we never think about it. So it's really important to focus that and switch that back on. So I don't know where my conclusion side has gone to. Maybe this is a subtle way of telling me that I've already talked for 5 minutes too long. There was conclusion text there. I don't know where it's gone to, but just to reiterate some of the main points, ankle sprains occur really frequently, and chronic instability results far more often than it should. I talked through 3 of the main reasons as to why chronic ankle instability occurs and why we're predisposed to getting these injuries. The first one we can't do much about, because that's kind of an innate human trait and it's a consequence of bipedalism. We can improve our diagnosis. We need to find better ways to target the subtalar joint. We need to be cognizant and have a high index of suspicion for syndesmotic injuries. And we also need to think more about how we can improve our research literature, potentially getting clinicians more involved, because unfortunately science has gone way too far towards a bar of statistical significance, when a lot of these changes patients won't even notice. In terms of improvement, I think there are ways in which we can improve our diagnosis. We do know some things about risk factors. We know some of the common impairments: master the sagittal plane, enhance postural control, train deeper angles, include a transverse load whenever you are challenging your patients. Think about the orientation of the ligaments, train our sensory motor system in the open chain, make sure that there's an opportunity for feedback. When it comes to strength, don't forget about the transverse plane. Don't forget about eccentrics. Move away from inner range TheraBand work. And also remember to think about training the shank on the foot in a closed chain and restoring pronation and supination. So don't ignore our inversion strength and don't ignore our transverse arch. So thanks again for the opportunity. And I guess there's maybe, so I'm happy to take any questions if people are still motivated and awake.
We do have some motivated wake people, so I'll give you a couple of these questions that have come in. Do you get imaging as a routine part of informing rehab, or only if you think that surgical intervention may be necessary?
No, I don't think it would be as standard, but I think if there's an index of suspicion around the syndesmosis and it's difficult to determine how unstable it is, or you suspect that the subtalar joint is impacted, then that can certainly help. I guess the issue with subtalar joint is that it's hard to restore surgically anyway. So even if you know that there's damage there, it's maybe not that useful, but certainly not a standard. There's still a lot that we can do just through our clinical tests.
Okay, what does the evidence support that generalized hypermobility is a risk factor for ankle sprains, or that they're more likely to develop CAI or become non-copers post-sprain?
From an evidence perspective, not that I'm aware of. There have been a couple of systematic reviews that have looked at risk factors, and they have only really focused on prospective research, and there hasn't been a massive volume. but I think clinically most people would agree that they don't tend to do well, and it is a bit of a red flag. I don't even think we need prospective research to know that. I think there's plenty of clinical consensus and there's plenty of cross-sectional work that would tell us that.
A couple of rehab questions come in. What about the thoughts on going early on using intrinsic foot muscle activation for the management of the arches?
Yeah, and again, it's really nice because you can do that straight away. It's not really excessively loading the injured ligaments, and it's something that you can do really from, I mean, if people can tolerate it on day 2, day 3, then go for it.
And there was a question on a rehab tool from that was designed in New York, Minis by Parasetter. Have you come across that for use in rehab at all?
No, I'm asking what it is, so I haven't.
I'm the same. Didn't get it either.
How is it spelled?
Just pretty much as I said, Minis by Parasetter. I presume Parasetter must be the company there, but Minis by Parasetter.
Okay, and is there any clues to what it actually does? It's a rehab accessory, or?
I've just asked for some help here whilst I ask you another question. There's a lot of people really thanking you for the information. A lot of really good session work information coming in, Chris. So there's a lot of positivity out there just now. Do you come across many posterior ankle impingement post ankle instability?
Yes. I think there are loads of reasons why somebody will have posterior pain. But I think if you've got greater levels of instability, then of course it increases the risk. Yes. The key thing is trying to figure out what is actually causing the impingement. Is it an FHL? Is it an OZ-trig? Is it a capsule? Is it a posterior? Because I think we forget there are lots of ligaments on the posterior aspect that can potentially be damaged, particularly with a high sprain. I think just make sure if that's coming up early on, make sure that it isn't a high sprain that's been missed, because if there is a syndesmotic injury that has been high magnitude enough to damage the posterior ligament of the syndesmosis, the posterior inferior tibiofibular, then there's probably significant impact.
Okay, I've just posted the link based on the Minis. They're from the physicalmindinstitute.com/minis if anyone wants to get a look. And they appear to be involved extensively in plantar fascial type pain. So there's a wee gimme right there. It's probably appropriate as we head into a football window, for some of us anyway, who haven't qualified yet for the Euros. Here's a great question to finish on. How do you manage international athletes who rely heavily on taping pre-match?
I think figure out why they need it. First of all, is it a strength problem? Is it a sensory motor problem? Is it a genuine problem with mechanical instability? Try and address it. If that hasn't worked, then don't worry too much about it, because I think there has been a supposition that lots and lots of taping weakens muscles and does all sorts of things, but I think the evidence would suggest that it doesn't. So long term, apart from maybe a psychological reliance, I don't really see an issue. It's obviously expensive, but so check your budget. If your budget's healthy, then I wouldn't worry too much about it.
Excellent. Well, that sets us nicely up to go and have an evening with sport. Thank you very much for everyone that's tuned in, whether you're interested in the football or not. It's been great. You've been interested in the ankle, and with Chris, whom is just such a quality speaker with so much evidence and understanding and knowledge behind him. So there's a number of you who've contacted right through the chat and other forums saying how good the session is. So thank you for attending. Chris, finally, thanks for pitching up,